On this clinical case, I wanted to take the opportunity to try another anterior BruxZir crown. We're going to be replacing the PFM that's on tooth number 8. We've got a new, more translucent material, and I really wanted to see what it was going to look like. You'll see that as we're taking the shade here, you'll notice that we've got a veneer, believe it or not, on tooth number 7. I know that looks like a crown, but it's not. It's a veneer. You might have seen it on the incisal shot that it was a veneer. And we've got the PFM on tooth number 8. We've got that natural, highly characterized tooth on tooth number 9, and then number 10's in crossbite. So I wanted to see what it would look like to put a BruxZir crown in there and how far we've come along on the translucency. I'm using the Vita Easy Shade Compact here as we go through and placing that on the tooth. And I'm getting, obviously, some conflicting results because of the gingival third and how characterized it is. But as I get closer and closer to it and shoot a couple more, this new Vita Easy Shade Compact actually has an averaging function on it. And so this 2R 1.5 that you see me using, it came up as the base shade as the average for the middle third. And then you can see we've got a little more chroma. And a 3M3 is what I'm holding up here. And again, we're taking a still photograph of that to forward to the technician, because this is really how we're going to make sure that we're going to get a nice looking restoration back. And you can see in this close-up as I put the topical into the sulcus and rinse it off, you can see all that characterization on that tooth next to it. Honestly, she does not have a very high smile line, so that's not going to make or break the aesthetic look of the crown. But what I want to do is a monolithic crown, and as we increase the translucency of the BruxZir material, it becomes a more viable option in the anterior. So here I'm using the STA device just to give a sulcular injection. You've seen me do this, I'm sure, before in the posterior for the rapid anesthesia technique. We like to do it here on some anterior teeth only if we're treating one tooth, and the reason we do it is the patient can still smile. Their lip does not feel fat or look fat for that matter. And sometimes it's an endodontically treated tooth and we just need some soft tissue anesthesia. And obviously that infiltration right into the patient's nose can be a very painful one to receive. And so a lot of times I'll use the rapid anesthesia technique right into the sulcus for that as well. That's a razor carbide burr from Access Dental, and I like it because it'll go through ceramic material as it has done, and now you can see it going through the metal. And so as soon as I expose part of the tooth, we cut it back a little bit more. And here I'm just using a cord packer to hold the tissue back because I still have a little connection up there at the gingiva where the metal, I haven't been able to cut through it, but I prefer not to nick the gingiva. So I'm using a cord packer, or you could use that Zakira gingival retractor if you wanted to as well. I just grab a cord packer because it's already there, and my assistant has handed me a crown remover that I'm not particularly fond of. It turns out the two good ones, we've been taking off crowns all day. They were both in the sterilizer, but I managed to get it off with that one that doesn't have the big beefy handle that I like. And the PFM comes off, and we see that there appears to be a little leakage, not necessarily on the tooth structure at the margin, but you can see that kind of gray line around the buildup. Maybe that was just from the metal, from me kind of working that coping back and forth. You can see it's an endodontically treated tooth. There's the head of the metal post as we see it on the lingual, and really almost all the preparation's been done. So I'm going to do what I typically do at the end of my prep sequence, and then is turn the water off and turn my handpiece down to about 3,000 RPMs, very, very slow. And using this 856-025 burr, I'm really going to go in and develop the gingival margin, or the gingival third, I guess I should say, and really make sure I have a very clear, distinct margin here. So the laboratory technician is going to be really able to see what's going on. This is the 856-025F. You can see the red stripe on the burr, and so this is a fine grit version, like a 60 micron version of the burr I was just using. This is what we're going to use to smooth everything off. I've really found that when things are nice and smooth for the technicians, it's very easy for them to see what's going on. This is Viscous Clear from Ultradent that I'm using. And again, it takes some pressure. You need to push that brush against that tissue and rub it back and forth to really seal off those capillaries. We don't want to be gentle and just kind of dab it into place. And even though on a BruxZir crown we could do something along the lines of a feather edge margin, I still just feel a little bit better doing this deeper margin that you see here, this shallow shoulder or this deep chamfer, whatever you want to call it. And in this particular case, we're doing what we call an in-house shootout. So in addition to the BruxZir crown that you're going to see, we're making several other crowns that are going to go in place just as kind of a progress check to see how BruxZir looks compared to these other crowns. And so one of them is going to be a PFM, one's going to be a Lava, one's going to be an Emax. And in order for those crowns to have a chance at looking good, I do need to prep this larger margin. And even though it's deeper than it needs to be for a BruxZir crown, if you were committed to doing a BruxZir crown, BruxZir's not going to look any worse with this deeper margin. So the double zero cord's in place all the way around. Both ends are tucked in flush, and then this number 2 cord goes on top of it. That's a 2E cord, where the E stands for epinephrine. And again, ever since I heard Gordon Christensen talk about using a cord with epi in it, I've been okay with it too, provided, of course, that the patient can tolerate a local anesthetic that has some epinephrine in it as well. And so since we want no bleeding, I'm going to use some EpiCord, and then we're going to use a pre-moistened anatomical Comper cap. And you can see it's anatomical because it's got little cutouts on the mesial and distal for the papilla. And look at that. We're going to remove that top cord, and you can just see there's just going to be no way that we screw up that impression. I don't know how we could. That was a wide open sulcus. We could totally see that we had exposure to the gingival third. There's no reason why our technician won't be able to give us just a wonderful emergence profile there. And that's the reason why I really like that 2-cord technique so much. There's certainly other easier ways to do retraction, but not many that actually give a result quite like we get with the 2-cord technique. And again, that's why we like it so much. So the next appointment, of course, with CAD-CAM dentistry, this next appointment can really be shortened up. We can do it 3 days later. You know, with CAD-CAM dentistry, you can almost do it the next day. We had to wait a little bit to get some of the bilayered restorations, the PFM and the Lava crowns back again. So we wiggle that off with some towel clips, and then I'll just use a micro brush to clean up any cement, which I probably don't need to do because we're actually going to go in before we cement this restoration and clean it up. So we tried in a bunch of crowns that you didn't get a chance to see because that was not something for the filming. That was just for our own in-house comparison to measure how BruxZir looks compared to the other ones. And the BruxZir crown did look very nice, and so at this point we're ready to cement. So that was the Prep-Ease, that pumice from Whip Mix that I used on the tooth to make sure everything was nice and clean. And that's the ADEC warm tooth dryer that we're using afterwards because it's got it's never had any water through that hose or oil for a handpiece, and so it really makes it a nice clean air source to make sure we don't contaminate the preparation. This is some G5 from Clinician's Choice, and in case you're wondering why in the world is he desensitizing an endodontically treated tooth, well, in this case, it's not for desensitization. It's because 2 1-minute applications. So I'm going to put it on, leave it on for a full 60 seconds, and then you'll see me evaporate it. And the G5 is, again, and it's like a lot of other products like Gluma and things like that. So it's a glutaraldehyde and a HEMA mix and a lot of water, which is why we evaporate it. Then we put a second 1-minute coat on, and this takes some patience to be able to sit and wait for a minute and let those 60 seconds go by. But if you do that, 2 1-minute coats of Gluma, or in this case G5 or HEMA Seal inside, you will kill, according to Relic Christensen, 99% of the bacteria living on that tooth. And so not only do we get desensitization of a vital tooth, but we kill all the bacteria living on the tooth. And according to CRS Research, we actually get a slight increase in bond strength to a cement as well, which is pretty wonderful. So because it's an all zirconia crown, my favorite thing to use is Ceramer as a cement. And you can see us triturate it there for 8 to 10 seconds. And then we're going to put it inside the crown. And because it's a glass ionomer calcium aluminate cement, it is not affected by salivary contamination. So we don't have to do the sandblasting or the IvoClean. We don't have to use something like the Z Prime Plus because of the fact that the phosphates are not involved in bonding. It bonds so well to the solid zirconia because of its hydrophilic nature and the fact that zirconia oxide, which is what a BruxZir crown is made out of, is also very hydrophilic in nature. And so after waiting about 40 seconds, we're able to begin our cleanup. And you can see how easy it is to clean up. In fact, it's the one permanent cement that kind of goes through a gel state. And so, you know, most of the cements that we're used to using, like resin-modified glass ionomers, go from unset to set pretty quickly, but this is still soft at this point while it's in its gel state, and it makes it very easy to be able to clean up like that and very easy to run floss in between the teeth and be able to get the excess off. And I've got a little excess around the margin right there that I'm getting off with my Explorer as well. So, the benefits of the Ceramer are the fact that it doesn't need to have the tooth preconditioned or decontaminated, and then there's no use or no reason to use a zirconia primer inside the crown. In fact, if you do use one, you'll actually weaken the bond because the zirconia primers, the surface of those are hydrophobic, and the Ceramer, which is hydrophilic, will not come in contact with the hydrophilic zirconia oxide on the inside of the crown. And so we've cleaned all that off. I've got one little piece of cement there I need to chase down, and we're just kind of rinsing that off at the time. We're going to check the occlusion and look at that on tooth number 8. Again, that's a solid piece of zirconia that is in place. It's just been stained and glazed. There's no cutback or layering. There's no any kind of layer of feldspathic or veneering ceramic on that. That is one of the BruxZir crowns that you've seen us take and, hammer into a piece of wood with a hammer before. And so we really did it on this patient because we wanted to see how much better the increased translucency works. Certainly, if you had a case like this in your practice and said, I want to use Emax for this, I would say, absolutely correct, doctor. That's a great choice. We're doing this more because we can. I've got a technician here who we give a lot of photographs to, and she's able to try to match that tooth. And for us, it's a matter of seeing, as we continue to make this material more translucent, how good can we make it look? I truly believe that one day these solid zirconia crowns will become the anterior crown of choice, when it does become translucent enough to really take the place of the lithium disilicate materials. But for today, it's still a good choice to use the lithium disilicate materials. But I think you can see by looking at this crown on number 8 that using zirconia oxide as our go-to crown in the anterior may not be that far away.